plantar fasciitis is the heading, but it's probably not. By the time we see most of them, they're a plantar fasciosis. Just as tendonitis, an inflammatory initiation of tendon disease, eventually becomes a degenerative problem and is a tendinopathy or a tendinosis, I think plantar fascia you'll see increasingly described as a fasciosis, a degenerative lesion of the plantar fascia. Now, how many of you here are seeing more plantar fascia patients? Fabulous, isn't it? Yes, good. Bilaterals?
No.
Sometimes. Sometimes, yeah. Sometimes sequential, one to the other. But it's certainly increasing in prevalence in the community. And there's a few reasons for that. One, again, is the baby boomers are at a stage where that huge bubble in the population have got soft tissue fatigue and are starting to wear out, and they're putting on a bit of weight around menopause and beyond, and are getting less active but want to stay, they're getting less conditioned but want to stay active, which is probably not a good combination. So that's a factor. The other factor is architecturally predisposed. I'm sure that there's a fashion in the last 20 years to less carpet in households and more hard surface floors in the service areas, okay, and in the entertainment areas as well. So people are tending to go on slate floors, tile floors, quarry tiles, timber floors are fashionable and a part of our current sort of renovation frenzy. And then we walk barefoot on them. We work barefoot on them too much, and we're not designed to actually do that. We're designed for a range of giving services and not that. So that combined with all those factors is not particularly good. The presence of a heel spur associated with plantar fascia pain is coincidental. There is no evidence that it's causative of the plantar fascia related symptoms.
It's really hard to convince people because once they see the spur on x-rays, I've got a spur.
The hardest people to convince are the orthopaedic specialists who want to take it off because they can. And it took me a while to work out that it's just not necessary. You can get them better without having the spur removed, and people got better spontaneously and still had a spur.
I just say to them, if you'd taken that x-ray 6 months ago, a year ago, the spur would have been there.
Yeah.
Did you have pain? No, you didn't have any pain. There you go. You can have heel spur.
Yeah, well, that's it. You try and reason. But there are others who will argue a different case. So be it. And I've seen a lot of these over the years and seeing a lot more frequently. And with all the stuff like this, I try and sit back and say, what I'm doing makes sense anymore in terms of aggressively treating these and stretching it and whatever. And I realised that people ultimately got better whether they treated them or not. Has anybody had one here? Personally had one? Did you have treatment for it?
I managed it.
Managed it? Managed it, exactly. That's a different thing.
Yeah. I don't think I taped it. I just stopped walking on the wooden floors in the morning, and I made sure I always wore shoes on the wooden floor.
Good. So you managed it, exactly. And I think that's what we're best at for managing this. I relate it as like a frozen shoulder of the foot. It's got to run its course. Once it's started there, once it's gone from inflammatory irritation to degenerative remodelling phase, which is what it will go through with time, it will reconstruct itself and it will adapt, and it will eventually become asymptomatic to general daily activity, but maybe high-level performance. It might start, if you go out to a ball somewhere and dance your legs off in a pair of shoes you only wear twice a year, it probably won't be as well behaved for a couple of days after that, but it will settle down. So my observation, which are listed in the manual here, fasciosis appears to almost get better eventually, but it's pretty miserable while you've got it. It's pretty miserable while you've got it. If you're on a weight-bearing career where you have to stand beside patients' tables and do your manipulation stuff, it can take a year or two. Sometimes it gets better with the treatment, sometimes it gets better in spite of the treatment. Surgery can be effective, often because they stop walking on it for a while. But perhaps not due to the actual thing. And it can be quite resistant, not changed due to any sort of treatment, but with time it will get better. Patients being patients and being impatient patients will shop around looking for someone to fix them, and there's plenty of stuff on the internet, plenty of things you can buy, ointments, inserts, special shoes, whatever, which are recommended and assured by endearing testimonials that this will fix your problem immediately. Please send money, and we'll send you the gadget. So, but there's no evidence base that any of those is any better than not doing anything in the longer term. So, injections, same thing. Surgery, no guarantee of help. So it sounded to me like it was a frozen shoulder, so I decided to manage it like a frozen shoulder and manage the loading of it rather than treat what I thought was a pathology. And so that gets you. So the unloading page here, critical factors to unload the fascia and allow collagen healing to progress without frequent interruptions of being on top of it. So these are my hardcore rules. In a handout, goes straight to my plantar fascia patients. Never walk barefoot in the morning out of bed. You must have by your bed a pair of pain-relieving footwears, either with their lamb's wool slippers or gum boots or whatever works best for you. Whenever you get out of bed, you go straight into that. Even middle of the night, going to the loo, you use those. You do not walk on hard floors straight out of bed. Because that is when the plantar fascia structures are least protected because they're full of accumulated fluid and they're least resilient. Never walk barefooted on hard floors, timber, quarry tiles, whatever. There you will have a pair of house shoes. You'll take off your outside shoes every time you come into the house and you'll go into your house shoes and you will use them on the hard floors. You won't walk barefooted, not even a little bit. Taping we'll do in a moment. Supportive footwear, something under the arch that's comfortable, rear foot control. If it's not hurting, it's a good shoe for you. Orthotics, yes, off the shelf is typically enough. I use the hook design. Can you just grab the little hook one in there, Jason? Yeah, that one. So that's my first choice of off-the-shelf orthotic for the plantar fasciosis patients because it does have a gap for that prominent tender heel cord that runs up the middle of on the medial board of the thing. Gives some arch support. It's got some wedging built into it. It's got the magic red cushioning button underneath, which is always impressive, but designed for heel pain, and typically that's enough to get them started, but I would usually use the taping, which we'll do in a moment to begin with. So
who makes that one?
Vaseline.
That's a Vaseline, but other brands will make them as well.
What's the name of that one?
It's a healed orthotic, basically. I can't remember what it's actually got as title, but it'll be in their website. Look it up and find it. But it just doesn't fill the whole shoe, and it doesn't need to. After just some correction of the rear foot and some support of the medial arch, so they're not depressing into too much pronation and protecting that tender heel cord, that usually will do the trick for them. Evidence suggests that it is associated with reduced pain and increased function using orthotics, according to Lee in 2009. So that's what patients want. Decreased pain, increased function. We can achieve that by putting something in their shoe. We should do that. So I have no problem with it. So that's their unloading strategy. And sadly, the best shoe I have found as a house shoe happens to be the world's ugliest footwear.
Crocs.
Crocs. The world's ugliest shoe are brilliant for managing fasciosis. Brilliant, because they are spongy. Because you can wear them in the shower. You don't even have to stand on the tiles when you're in the shower. They're reasonably cheap for footwear, and if you don't wear them outside, they'll last pretty much forever. So these are your house shoes. They're ugly, and you only wear them inside because you wouldn't want to be seen dead in them anywhere else. So they make a great. Now there are variations. Rivers make a cheap version and other generic versions. I'm not going to speak to them because I know that the original Croc was actually built with a rear foot wedging mould built into it for the rear foot varus valgus control. I don't know about those other ones, but I suspect they just stole them, so they probably all are. Probably sent one to China and said, make us something like these, thanks. Which is what happens. So that's good. So getting a, but that doesn't have to be a Croc, whatever's comfortable. Lamb's wool slippers are good, Ugg boots, whatever works for them, that's good. But they may be too hot in summer, so you've got to accommodate. So, but the main thing is they use it, and use it devoutly. It's really important to minimise that, particularly that early first step trauma. And then the management afterwards is they get the unloading bit, and then the management, I do get them to ice, even though I'll say it's not an inflammation anymore, but they do aggravate it each day being on it. So I think there's an element of ongoing inflammatory annoyance, even though the lesion itself is gone on degenerative remodelling phase. Stretching with compression comes stretching with using the frozen Coke bottle or the tennis ball, squash ball, whatever fits the size of their foot. I don't think it does any harm, and it feels nice. So at the end of the day, it also sets them down to have a rest, yes.
I love juggling balls.
Juggling balls?
Because
okay.
they're not quite as mean.
So they're the birdseed filled ones?
Yeah. Or
Yes.
I get the kids, I get some of
Yes.
the patients' kids to make them with
Yes.
balloons
Yes.
and rice,
Oh,
or
right.
the nicest is kumquat, squeaks,
Okay, all
and
right.
a few ones. It's just not as hard.
Yeah.
Yes,
The
yes.
others is really kind of
Okay.
cruel when they're
All right.
really sore.
Yes, so it doesn't have to be cruel. I'm not a great condoner of being cruel to these things, so that would work fine. through to day stretching. Yes, I do think they should be stretched because we want to, as this tissue remodels, we want to provide it with a tensile loading pattern which will promote the alignment of the collagen, collagen molecular bonding in the order of the loading. So certainly getting into calf and fascia stretching and flexor hallucis longus stretching with the toe up individually to get the hallux up. And there's some level 2 evidence from Shippett's paper on that, that it will assist recovery in plantar fasciosis conditions. The aim is to control the pain, keep them as functional as they can be, and wait for it to get better. Wait for it to get better. I was at a men's health seminar recently, and Steve Biddulph, who writes a lot on men's health, said, he was talking about parenting boys, and he said, I'd love this stuff. We're going to use it for us, but I steal it from him first. He said, the role of a parent is to keep their kids alive until help arrives. That's true. Yes. So the role of the physio is to keep their patients functional until nature arrives and looks after it. And there's a statement way back in ancient Greek history that nature is the best healer, and the role of the physician is to keep the patient occupied while nature does the work. So this is not a new concept. This goes back to Hippocrates back in 3000 BC. So the concept is, have we moved on? I'm not sure. But in this case, I think it's going to get better if we can stop them annoying it. We help them stop annoying it. And make sure they don't gain weight, make sure their diet's good, make sure their immune system's strong, make sure they understand the link between loading and delayed healing, and then put them on the right path. They will still shop around, but they will come back to you because you're the only one that's told them the truth. You know, I can't fix this, but I can help you get better. It's a big difference. I can't fix this, but I can help you get better. They're listening. So that's good. So let me show you my preferred plantar fascia unloading tape. It's easy. You can teach a housemate, a partner, a spouse to do this for them because it's an important part of the unloading. My goal is to have them walking out of the clinic without pain on day 1 because then they'll come back for day 2. All right, so has anybody got an active one at the moment?
Mine's still a bit tender.
Still a bit annoying? Good. Well, if you can't giving up your foot for science, we'll put this on. So have you got pain walking around today?
If I sit down for a while, I'll be stiff.
All right. This is the one. Good. Good further. So
That's the list rectum.
that's this right. She had that. Okay.
Yep.
All right. But again, allergic to tape. Good. Okay, because we don't use underwrap with this. We put on an anchor strip with no tension because we don't want to compress the transverse arch of the foot. We want to make sure it has the ability to flatten out as it's designed to do so. So just loosely on, but an anchor strip. The taping itself is, we start from a mid position, and I want you now to make a fist with your toes. Scrunch them up tight, that's good. Make a big arch. I'm now going to tape around there to my anchor, and then I'm going to bring the other one around underneath to the anchor, top. I'm just going to close them down from the top so that your sock doesn't disturb that. I'm going to say go for a walk. That's it.
So I like it.
Like it. Okay. So immediately we've taken all the tension out of the medial longitudinal arch. It does. You've now got a more stable foot because you're not falling into pronation. So function-wise, it's improved, but more importantly, symptom-wise, you walk and they get off the toe. So that's fabulous. They feel so much better.
So that's why I think athletes are not good. You can get so much pronation.
Oh, you can. But you can
Especially
take them and wear
older
open.
people don't replace open, so they're going to be old.
Oh, yes, I hate to think what's living in them. Oh, don't even go there. But so I put this tape on, and so I want you to wear that for 24, maybe 48 hours at the most.
You
and
just
then
do
come back
one.
in.
You just do one every figure eight.
Her size,
Yeah, that's enough.
1 will be enough.
Mm-hmm.
Big fella here, 2, we do 2, because he's going to load it and stretch it out a bit quicker. Come back in 2 days, or take it off in 2 days, come back in 4, they come back, it's still there. Come back in a week, it's still there. And a week in Queensland wearing foot tape, it's not good. Their skin starts to rot and fall off, and it's just a mess because you can't retape. It's really important they get the message, got to take it off because we need to use it again. But it feels so good, they're reluctant to take it off. And you understand that's why you need to get them into a tape. Once we know it's helping, and it's not going to be forever, but for the next couple of weeks, every night, take it off. Every morning, put on your house shoes, your Crocs or whatever, do your toilet stuff, and then get somebody in the house to tape you for the day. Because it's not difficult to put on once they come in and learn the tricks, okay, and learn how to monitor the skin, etc., and look after it. So that works well. So let's, is anybody else? I'll just do that once again before we go. So
I've had it, so
Not yet, okay.
I don't like mine.
Yes, somebody with a whitish foot. So look at Sue's, stand down first, look at Sue's lack of arches, because they're going to be different in a moment. Which one would you like done?
The right one, but that's more
Okay.
bad for an
Of course I'll be kind to it. Oh, I can't. You think I'll be anything other than
Oh,
kind?
it was actually finished on a muscle injury course when they subluxed my foot.
Oh, it's all right.
Red. And now it's up.
Okay. All right, so I'm going to say taping from the middle. So now, if you're not particularly tape friendly with your hands and you want to let that go, that's okay. You can just leave that one up there and concentrate on one side at a time.
Do you want me to do the make a fist?
Yeah, make a fist. That's it. Is that all you got?
Yeah.
No, don't plan a flex. Just make a fist. Thank you. Okay, there. We'll come back, retrieve this one. Put it away. Fist. That's good. And relax. Got to be quick because I'll go into cramp. They'll start to get cramp if the plantar toe flexes, and they won't be happy with that. And it doesn't matter if you get wrinkles here, it's not weight bearing, so the heel's clear. Here's the other thing I didn't mention. The other thing it does is it builds a fat pad. It forms a little pad, a buttress over that calcaneal plantar surface to give a bit more protection as well. So I think it has two effects. One mechanical, the other it bolsters the fat pad by giving it a buttress around the medial and lateral sides. Okay, off you walk. And we should see a different shaped foot.
Have you heard of anyone injecting the fat pad to give a bit more
Like,
cushion? Yeah, exactly.
Collagen and
Makes
not
sense.
collagen. So,
Botox.
Botox, well that's a neurotoxin, isn't it? That's a different thing. Okay, and
Nice. Tight, that's nice.
tight, I want tight. I
Yeah,
want tight.
all
The only thing I don't want tight is around the metatarsal head. So we
Yeah.
stayed back a little bit because you're a little bit angry up here. Otherwise we could come. But yes,
Does she still
Yeah.
around the tape? Would you put another
We do it
there
here.
or not?
You're
Just
right.
leave it.
I just put my orthotics on.
yes, that's right. She'll put her orthotics in, and she'll be able to wear them with that as well. So that'll be
But it's
fine.
Sunday, so I'm not really.
But I want her to have no pain on the weight bearing phase. It's a straight away relief. And she'll be encouraged to follow the rest of the program if you demonstrated that you can take away her pain. That's good. So if this person understands how to remove the pain, maybe these other things will give me relief.